I don't know. I really don't think he has, but I'm not sure.
One more tap and thank you. Nothing tight, huh?
Yeah, well, for some reason, everything's tighter than it used to be. You know, I just twist this bottle or two.
Oh, what can you do? Well, camera works, then the car was small and face it.
I wish this worked with my computer because I don't know how to use this thing. Good morning, Tim.
Set the microphone. Have you?
Yeah.
Yeah, this.
Good morning. I will be on the Zoom call this morning.
You what?
So I will be on the Zoom call this morning.
Oh, okay.
Have to be in the city.
Oh, geez. Okay.
How's everything in Claremore?
Good. Building too fast.
Oh, is that going on everywhere?
I'm gonna want to gotta figure out some of the acres on my planet. You gotta stop getting more people.
Well, I quit.
It's a arithmetic.
I tell you what, I wish. There.
Oh, you're bad. Yeah.
So I should probably pay attention and watch how you do this.
Yeah, so plug it in there in the bottom,
Okay.
and then it just goes into one of your USBs.
How do you make the computer?
And then,
Oh, default has changed.
perfect.
Okay.
Yeah.
So we're ready to go.
Yep, so you're ready to go and the green light's on.
Okay, I'll turn it so it faces the podium.
Wish we could find a longer cord and just put it right on. You know.
I know. Well, we can move the table up. Well, I don't know if we can move it that far.
Yeah, so that's fine.
We'll have this all figured out by the time we decide we don't need to do it.
Exactly, right?
Why is it so shaky?
Yeah, I'll tell you when we have some.
It's rather fuzzy.
Shelly, Mercer.
Hello, hey, Shelly, nice to meet you.
Welcome, we're glad you're here this morning. You know, when you give a talk like this, people start going, do I have that?
This is about children, so hopefully you all.
Billy was telling a story about his wife. He said, his wife said, I think I got that disease. He said, you can't have that disease because you don't have testicles.
I was a little kid. My brother.
I know, I feel off. Oh, I feel off today.
The doctor started asking, she was drinking about a half gallon of V8 every day.
Oh.
And a carrot, I guess.
Oh,
yeah.
Baby carrots.
Give her a little baby carrot.
Baby.
Yeah.
That's great.
Love the win the food tie.
Well, it's good, okay, good.
How you doing?
Shelly, do you have your thumb drive?
I have to.
Well, it's always a toss-up if we can get it to work or not. So.
I have my computer too, in case I need that.
Well, my computer's a
Try
Mac.
that, my work computer encrypted it, so I don't know.
Well, my Mac will not show on the screen. So this is a PC, so.
Yeah, mine's a PC.
Okay.
Well, yours doesn't.
Okay.
So what's your son's name? He is the backup. Oh, congratulations. Thank you. Yeah.
There's a problem with the, it says scan it and fix it, says there's a problem with it.
Okay, try this one.
Okay.
That was the one that my work computer did.
Let's see, upside down here. Is it there?
Yeah.
I know, they're always so hard.
Okay, you play with it.
There's no audio or anything, but it is kind of a big file. And I probably have 45, 50 minutes of slot. I don't know how long you're.
Yeah.
You know, probably 30.
30, great. We can make it 30. Any,
And Megan in the back will like do that. I mean, you got like 5 minutes to shut it down.
okay, I can go fast.
Okay.
Do you need this for anything? Not.
Oh, great. Now we go back to,
So we'll just click on there and it'll put it in slide mode, okay?
And then will I advance it
Yeah.
just on here?
Or
There's a remote.
Jim, oh, there.
well, there was a
There we go.
Where's the machine?
Just put it in slide mode.
Thanks, sir.
And then I brought a few like sample pumps and
Yeah.
devices. Is it okay if I pass those around, or would you like to just?
No, we just start them over here and we just
Okay,
get them.
I know.
I'm not sure where the back is.
Barbara, where's the bag?
Where's the bag?
Oh,
Right there.
there's the bag.
Okay, but we need to go back to,
Small thing right there.
how do we get back to, minimize that? And get back, we need to get back to the Zoom.
All right, good. Just drop, yeah, right there.
Okay. And we may have no one on Zoom. Well, no, Mike Bibby's gonna be on Zoom.
I'll be on Zoom.
And you'll be on Zoom too, okay, on your phone.
Yeah.
Okay.
Now, we're still got her up here on the.
That'll be good.
Guess we know she won't be able to present.
So, well, that would be okay, I think, because,
Hey, Shelly, if you want to put them out right here, that will be helpful.
It's backwards.
But we can get it started. I'm gonna
let me go to the video options.
Yeah.
We got that, just a little ways.
See how that works.
Somebody's on because they're waving at us back here. Two chairs.
That's like with the old public water supply.
Yeah, let's go see.
I bet, yeah.
Where is it? Exit full screen.
Some voted.
Now go to. I guess that's what this is.
Rent a small sailboat for years. Nobody rents them.
Oh, this is the one from last week. Oh my God. Oh, okay, yeah.
Good morning, everybody.
Okay. Yeah, it's great. Okay, it's good now. You can be seen here. Now, when she gets ready to go to slideshow, I think she goes over to the slideshow. Okay, I'll just push this down right now.
Okay.
Okay, great. Thank you.
Still not showing on the screen.
Yeah, it was.
I mean, Zoom.
Oh, the Zoom's not showing. Well, let me, I don't know. Hi, Steve.
Good morning, Barbara. Hi, Tim.
Hi, how you doing?
Good. Just wish I were there.
We did too.
Thank you.
Zoom is the next best thing.
I have no idea.
Okay, well, it's not backward now.
5 years. I'm technically attended 49
Well, as long as they can see, that's fine.
That's true.
We don't have to see them. I mean, we can see them on the PC.
Police chief invited me to come to the program. He told me if I ever got trouble, call him. He'd make damn sure he's free.
Oh, now it's going through the whole slideshow.
Okay, good. Now it's working. Okay.
I have never cruised no record. What I do, get coffee in that Pam hospital.
So it maximizes that. Okay. Sounds good.
Okay.
So now it looks like it's going to work.
But do we probably need to at least see who's on.
Oh, yeah.
Just gonna have to see him, yeah.
There you go.
Thank you.
All right. I'm going to head on to open sit.
Okay.
All right.
Drive safe. I think we got it all figured out, but we'll find out when it starts.
Okay, just in case I forget, $5 happy buck from me for Jesse taking over for the newsletter for the last 2 weeks.
Okay, it's too loud in here. I can't hear you. $5 for what?
$5 happy buck for Jesse Poole taking over the newsletter last 2 weeks.
Put it in the chat. Can you go to the chat room and type
Yeah,
that out?
sure, sure.
And that way I won't forget. And also I can't hear you, so that's good.
Okay.
As far as I know, he hasn't been back up
You look great, Mike.
Good morning, Steve.
Good morning, Scott.
Well, Kirksville is not.
She said she got a little picture.
Well, it had to be.
Hey, down there in the valley, she didn't know that, they could be great. Very odd.
Good morning, Steve.
Morning, Joy. Oh, good morning, Stan.
There is a mean virus around right now, and that's why I'm not at the meeting, because I'm ill.
Hey, Mike, good to see you up and joining us.
Well, I'm not as good as I appear to be. I've got a lot of pain in the leg and hips, but it's going away. It's getting better. So it's just a matter of putting up with it till it goes away.
Fantastic that it's allowing you to participate.
Yep.
So Mike, it's in your hips, you say? You have pain in your hips?
They fused the last two discs, L3, L4.
Yeah.
And so now I'm bionic man. I've got metal in my body.
Hi, Gifty.
Hi.
Good morning. Morning, Steve.
Scott Sires are ROD today.
Oh, hey, man, are you trainable? Wow, I don't even have to say.
Jasmine.
Come on. We've been down this road before once or twice, right? All right. Hey, let's bow our heads and say a prayer. Heavenly Father, thank you so very much for being with us today. Thank you for the food that this place has prepared for us, the parts that go into preparing the food. Thank you for all the Rotarians, not only in this club, but across our district and nation and international, for all the service that they do. They put themselves out there so that they can help mankind and make sure that those that can't help themselves are helped in such a way that it makes it a helping hand instead of a handout. Thank you again for all the things that you have given us. Thank you for the medicine that we have in this wonderful country. May we share it with the world. May we share our knowledge with the world. Be with us all as we go out into this world as Rotarians and as humans, so that we can touch and shine your light within our hearts. Okay, let's take the pose. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. All right. Let's have a seat.
Turn it on. I love that idea. First thing you ask, is it plugged in? And now we have this video.
I caught her before she went on. We have to remember it's 7 o'clock in the morning. All right, good morning. Hope everybody's doing well this morning. All right, I think we have some visitors, returning visitors, which is exciting. We have Alex is here. And you should, basically, I think we have Mercer, which I'm really excited about. And then I think Megan is here again. Thanks for coming. Visitors, let me see. Great. I'm sorry? Oh, Jack Freeze. There he is. Hi, Jack Freeze. I'm glad you're here today.
Hi, Jack.
All right. Are there any birthdays or anniversaries? Barney pointed you out. He got the finger on you.
Mark, is that me? Anyway, my mom sends me a check every year for my birthday for however old I am. It's kind of a smack in the face, but here it is back.
Yay!
75.
Happy birthday. Any other birthdays or anniversaries? Martha?
My happy buck is that I finally have some dollars to do a happy buck. Because I haven't had any money. And so I haven't had a happy buck in the last 3 or 4 weeks. So, yippee, happy buck!
She's saying beautiful.
I have to tell you that if you remind me, it's okay. Friday night at Mayfest, the Tulsa Corral sang behind AHA to a small crowd of people. Hopefully some people were streaming it, and it made my daughter-in-law cry. So that made me feel so good. She was so moved by the music, and she's only 32 years old. So look at all these old people that we sang something that meant a lot to her age. So next time I have a concert, which will not be until November, I will be telling you more and more about it, because I want to move some of you to come to our concerts, because they really are wonderful, and you leave feeling better than you did when you came. All right? So.
Oh, Steve Kerr. All right, Steve Kerr, you the happy back? Steve, you're on mute. You're on. Oh,
There we go. Can you hear me now?
I can hear you. I may have to repeat what you say.
Okay, well, $5 for Jesse Poole taking over the newsletter for the last 2 weeks. Much appreciated.
Oh, he says that he is very appreciative of, is it Jesse who's taking over the newsletter? Is that right, Rod? Yeah?
Right, $5.
Oh, $5, he says. Huge. So good job, Jesse. I don't know if, is Jesse online?
I don't see him.
Well, thank you. Good. Good. Oh, Mike Bibby. Go ahead, Mike.
Okay, I've got 10 happy bucks. 5 of them is because the surgery I had was successful. I have no more pain in the hip and left leg. The other $5 is pay for an advertisement. I need a walker. Anybody got a walker that I could borrow?
BJ will have one. BJ will have one. That is what I told, that they just said. So that's $5 because he had a successful surgery. Mike, we're so glad you're well. And then we miss you today, of course. And $5 more because he is looking for a walker. So,
Hey, Mike, I got a walker for you.
oh, that's Stan?
Yeah.
Stan has a walker for you. I
Cool.
couldn't believe we were talking. Like,
Stan's marker will be there.
okay, got it. It's probably true. I'm with
I'll
you.
even deliver it, Mike.
All right.
And I would appreciate that.
All right, any other happy bucks online before we go out to the audience here? Okay, anybody else? Happy bucks, or did I hear someone has an anniversary too? Oh, yeah. Does Joe, do you have something? Because Don just called you out.
Good morning. I'm happy. My son Austin is back from Abilene, Texas. He graduated and college, magna cum laude. Like Lottie, how come kind of thing. But he did great. I'm glad he's back. I actually have one more thing. I have a son as well, Henry, and he went out to California to go to school at UC San Diego. And then he stayed, and he's been gone for 10 years. And then with the whole COVID thing, they're all cooped up, and he said, I can't afford software. Bought a house, and he has one child. He's got another one on the way, and I'm just as pleased as can be.
Awesome. All right. We got another one.
Barbara Smallwood, software, whatever I am, retired. I'm going to Denver, Colorado, to Golden, Colorado tomorrow. Granddaughter graduating from Colorado School of Mines on Friday.
All right, Scott Cyrus, pediatrician. I'm not, hopefully I'm not stealing Stan's thunder here, but I'm happy that the FDA has the new requirement for 12 to 16-year-olds with the Pfizer vaccine. So now they passed that, and we can start to get our kids immunized. So I'm really tickled about that.
All right.
Are pediatricians going to have it available to them, or they still go to do it?
Most likely, the pediatricians, especially the Pfizer vaccine, because it's such a cold storage issue, won't have it in their office. So we'll still mostly be sending them to the central location. Yeah, we won't keep it in our offices just because of the cold storage. Now, the Johnson & Johnson vaccine and Moderna don't have that same, so they may be starting to market it to the pediatricians just to make it more available to the populations.
So this is Stan, I might say we're meeting today to make recommendations on the 12 to 15-year-old with the Pfizer vaccine. And they are going to be shipping it to pediatric and family physician offices. I think there's a short window of opportunity that you can use it.
Okay, so there may be some in pediatricians' office.
Yep.
Okay, thank you, Stan, that's great. Good news. All right. Any more? No. All right. This morning, I will admit, I was at my son's state golf tournament for the last 2 days in the over wet rain. So I'm just like a little groggy. So my joke, I'm not sure. I'm gonna make sure. Okay, here we go. One night, a state cop saw a car going only 22 miles per hour. He pulled the car over. When he approached the driver's side, he noticed 5 cute ladies were seated in the car, and all of them looked to be in shock. They were all very pale. The old lady driver greeted him. Officer, why did you pull me over? I was going the speed limit. Exactly. What is the issue? Man, you weren't going over the speed limit. However, driving under the limit is just as dangerous. but I was going 22 miles per hour, the exact speed limit. No, ma'am. 22 is not the speed limit. It's the route number. Feeling embarrassed, the older woman thanked him. Before I let you go, is everything okay? The other ladies seem a bit unsettled. They'll be fine in a minute. We were just on Route 119.
I don't have very many announcements today. Saturday is Ines and I work day for Sunrise out at the location. If you would love it if y'all would come. Also, it's Food Bank at Jinx, and that is. What time, Bill? 10? 9 o'clock at Jinx Food Bank. So we got a lot going on Saturday if anybody wants to feel like they're getting the service out there. Next week, hopefully, we're going to have 2 inductions of 2 new members, Evan Taylor and Alex London. We're looking forward to that. So that would be a special meeting for us. And then the following Wednesday, we're going to have Club Assembly. And that's when we're going to all participate in the discussion of how we want our fundraiser to be. So be sure and attend that. And I don't have any other announcements.
Barbara?
Yes.
Cole wanted me to remind you about the DAC TV training. on Thursday.
Yes, DAC TV training. I sent a note out to the board. Cole has set up a Zoom DAC TV training session for tomorrow evening at 6 o'clock. And if you're going to be a member of Rotary, we really need to get into DAC TV because there's so much information about our club, about history. If you want to know somebody's phone number, you can go out there and look it up. If you want to know anything that's outside, you can look it up. Or Google it, whatever. But really, there's a lot of information out there on DAC TV. You have a chance to attend.
Morning.
Report.
Morning.
Is somebody talking on Zoom? No. Bill, lost the question.
I was going to say, in state roads, the rest record, other things.
No, we won't go there. So I have nothing else, so we're going to have Scott come back up as ROD, talk about himself.
I got thrown again.
And if anybody on Zoom has something to say and I can't hear you, just raise your hand.
Barbara, did you say that?
No, we're having, I think I told you wrong. We're having a meeting, the committee's meeting after Rotary next week. And then we're going to have the club assembly on the 4th. So my apologies if I sent you the wrong information. We changed speakers, I think, so we can adapt that. So.
Hey, good morning, everybody. Scott Cyrus.
All right.
How's everybody this morning? Good? All right, we're a rowdy bunch and everything. And I wore my mask up here because I wanted to show you all something. You know, when you're a pediatrician, you got to be ready for anything. You absolutely have to be ready for anything because kids will tell you anything. I used to have a gold tooth in the back of my mouth. Every time I opened my mouth, I said to the girl or little boy, say, Dr. Cyrus, you have a cavity back there. It's like, no, just open your mouth, you know. So now the kids look at me, and as I come into it, they look at me and go, Dr. Cyrus, you look like a duck. And I said, you're right. This is really called a duck-bill mask. It's an N95. It's a respirator, actually. It's called an N95 duck-bill mask. I said, but I may look like a duck, but I'm not a quack. So I had to come up with that in a hurry. It was like, okay, what's my comeback to that? Because I mean, every kid out there does that. So anyway, Scott Cyrus, I'm a pediatrician. I love my job. I've got to thank Stan Grog always for getting me into this. He was my mentor, and I wanted to, believe it or not, I was a EMT, or I was an orderly before I was an EMT, and I was an EMT before I was a nurse, and got my degree in nursing, and then I was, of course, a nurse before I was a pediatrician. Now, I was working in St. And so I was the orthopedic nurse for St. Francis, our largest trauma center in the state of Oklahoma. And so as a trauma nurse, you work with radiology, you work, of course, in the ER, and you work with orthopedics. And I worked with a lot of kids. So when I went to med school, I thought, well, that should be one of the core things that I really wanted to do was one of those 4 things. And my personality is to get out and be among people and like to watch people and talk to people and everything. So radiology being in, shades of gray and in dark and wasn't going to be my bailiwick. I like long-term things. So, ER was like, well, you got to, treat them and street them is the term for ER. And you're kind of like, well, that's not long-term much of anything. So I thought, well, orthopedics is really, really good. I think that's what I'm going to do. So I did all my rotations in 3rd and 4th year in orthopedics, and lo and behold, didn't get into the residency, and I tried again, and finally I went into family practice, which really drove me crazy for about 6 months. And the adults are just like, okay, sorry. You all got way too many bad habits. So Stan looked at me and said, why don't you come over and do pediatrics until you figure out what you want to do? And sure enough, he opened the door, and that's where I stayed, and just I love it and everything. So not that any branch of medicine is not great, but for me, pediatrics really has been home, and it's been great. And it's just been fun to watch kids grow up. It's been fun to watch kids grow up, get married, have their own family. I had a 24-year-old in my practice because he couldn't find a doctor that would treat his hypertension because he had this problem with his heart. So the cardiologist calls me and said, I want to keep him, the pediatric cardiologist is going to keep him in his practice. Would you keep him in your practice? And I said, well, I'll keep him in my practice until he starts doing adult things. He said, okay. So he came in at 24, and I said, well, how's it going? He goes, oh, I'm doing good, And I said, well, anybody, you seen anybody? He said, no, I'm not seeing anybody. I said, okay, well, just remember, if you start doing adult things, then you gotta go see an adult doctor. Next time he comes in, I said, well, everything looks good with your blood pressure. We're gonna keep treating it. And you have a girlfriend or anything? He goes, oh, yeah, I got a girlfriend. I said, well, remember, if you start doing adult things, you gotta go see an adult doctor. Well, next thing you know, he's getting married. And I go, are we doing adult things? He goes, no, we don't do that until we get married. I said, okay, but remember, you do adult things, you gotta go see adult doctors. Sure enough, next time he comes in, we're expecting a baby. I said, that's it. I know you're doing adult things. So anyway, it's like I said, it's a lot of fun. Then they start bringing their babies back to you. So you either know you're getting old, or you know that you're doing something right. So anyway, I kind of like to think of the latter and everything. But I enjoy it. I have 5 grandkids of my own since I've been ROD, so I think a lot of things have changed. But of course, you all know I'm the professor of pediatrics at the Burrell College of Osteopathic Medicine, the greatest medical school in the state of New Mexico. Of course, Megan is from that school, and so she, the students honor you when they come all that way to rotate with you and everything. So it's a lot of fun to teach the students. It's kind of paying back, those that have taught you, and Stan was instrumental in doing that. He was instrumental in letting me in here. He blinded everybody and said, let this guy in here. But and it's been a lot of fun to get back to because it's like I said, when somebody brings their children to you, it's really an honor. It really is. It's the most precious thing to most people's lives. And they bring them to you and say, okay, will you take care of them and everything. So it's a lot of fun. So I'm going to introduce Dr. Shelly Mercer. She's a pediatric endocrinologist, and I'll tell you right now, specialists in the world of pediatrics are gold. Okay, they are absolute gold because they just it's just a long road to become that pediatric subspecialist. Being a pediatrician, it's a 3-year commitment to residency and you get out. But then you have for a pediatric endocrinologist, she was in Alabama for her internship, her residency, and her fellowship. She was a Bama girl for 6 years. Okay? She was a Bama, yes, that's right. No lasting effect, but she was a Bama girl. But anyway, she graduated though from the University of Oklahoma. Redeeming factor, not good. There you go. But yeah, she and I have a similar degree in zoology. Now, what do you do with a degree in zoology? Well, it gives you the permission to go out and shovel poop at the zoo, is what I thought. Because you have to go on to med school. And she graduated with that, as you said, Andy earlier, she graduated with summa cum laude honors. So smart, very smart. So, and then of course she graduated from OU Medical School too. So she returned to Tulsa in 2018 and as an OU assistant professor in pediatric endocrinology. She's board certified in pediatrics and pediatric endocrinology. She works on several trials. You know, as a professor in a university, that's one of the things that you really are kind of asked to do, is to be a part of research and be part of clinical trials and everything. And so she's doing that. She's teaching and mentoring medical students and residents, and as well as seeing her patients. So she's busy. She's really, really busy. She also serves on the Juvenile Diabetes Research Foundation Board of Directors. She's the camp doctor, which is fun to be a camp doctor because I did it for Ryla one time. It was a lot of fun to do it for Ryla, but camp doctor for Camp Blue Hawk Diabetes Camp. And she's the face of Channel 8's Good Morning Tulsa for Diabetes Awareness Month in November. So that's a good face for television. Okay? Well, listen, give a big roaring welcome to Dr. Shelly Mercer.
All right.
It's quite an honor to be here. You guys are a lively bunch this early in the morning. I want to know what's in your coffee. I'm always up this early, but not normally quite this joyful. So thank you again for having me. I wanted to spend this morning speaking to you about a disease process that I see on a daily basis. It's near and dear to my heart, and I think it is important in an advocacy sense to highlight the difference in type 1 diabetes and versus the more prevalent adult type 2 diabetes. Because it's a very different disease, and in general, it can be very confusing for people with this condition too. So I'm going to run through those differences and talk to you a little bit about some of the diabetes technology that we are using right now, which is really exciting. I actually brought a few pumps that I want to show you guys that our kids are wearing, and be able to share that with you. We may need to go on the PowerPoint.
Yeah, maybe. All right, try it now.
All right. So first of all, you said thank you for inviting me to the Tulsa Sunrise Club. My Rotary connection is through married into a wonderful family. My husband's grandfather was LeVan Kelly. I don't know if any of you all know his name. And he was very involved in the Bristow Rotary Club, and I believe was district governor. I wasn't exactly sure what the title was. So I'm going to give this talk in his honor, and he's so appreciative of everything that your organization does. All right, so just as a few objectives is what we always do in lectures for medical students and residents. Talk about what we're going to talk about. So I love going into the history of things in medicine, and I'll give you guys a brief background on diabetes and insulin as well. Reviewing some pathophysiology, so you get to go back to your basic science class. I mean, you guys are excited about that. Management, how we treat these kids, and again, technological advancements. And then I'd like to tell you what we're doing at a local and national level to support our patients. All right, type 1 diabetes. So up until mid-1800s, we were diagnosed this disease based off the taste of glucose, of sugar in the urine. So if a clinician had a clinical suspicion that their patient had diabetes, they would ask their house staff, so someone in Megan's position of training, or where I was when I was an intern or resident, to actually taste the urine of the patient. Can you imagine? I mean,
Shoot universal precautions right in the head.
right. We fired on spot today. So that we are very thankful that we do not have to do that. I don't have to do that every day. But we weren't really measuring blood sugars until 1915. Okay. And then this is actually the 100-year anniversary of the discovery of insulin. So it's pretty remarkable. We've known about this disease for centuries. We knew sort of what was wrong, but we had no way to treat it up until about 100 years ago. Okay, so very remarkable advancement. Before insulin was discovered, this was a death sentence, and this was diagnosed in children. So they were 86% of children were died when they had this diagnosis. And if you weren't dying from this disease, the treatment was as close to death as you can get. It's extreme caloric restriction and almost zero carbohydrates. Because that's what when you're in a state of insulin deficiency, you can't process the sugar that you take in. So these kids were getting about 450 calories per day and no carbohydrates. The example that I read as far as something in their diet would be some green beans that they would boil 3 times to try to remove almost all the starch. So that's what the kids would get to eat. So they were just completely, it was starvation, essentially, to keep them in a very low metabolic state so they didn't need their insulin. But as you can imagine, not a great lifestyle. So Doctors Banting and Best first discovered insulin in 1921. And how they came about that was they would remove a pancreas from a dog, and they could see that the dog developed diabetes. So they knew there was something within the pancreas that was really important for the development of diabetes, but they weren't exactly sure what. And then they would grind up the dog's pancreas and inject it back into the dog. And it worked. It cured the diabetes temporarily for as long as they were getting insulin. And as you know, with the pancreas, there's a lot of enzymes that are released to help us with digestion. And so those would cause huge problems in the skin at the injection site. So they weren't able to really purify what is now known as insulin until 1921. And then from 1921 through the 70s, when synthetic insulin and the man-made insulin was made, we were using pancreas from cows, sheep, and pigs that were ground up and purified and then given to people. So we've really come a long way in the last 100 years. This is the miracle of insulin. Right around the time when insulin was discovered, this is what a child with nearly, or it could be several months or years, with diabetes would look like, just severely wasted. And then this child was given the synthetic insulin, and you can see a very remarkable difference in a matter of 2 months. Right, nice plump cheeks. Cachectic nature is gone. He's really just able to thrive metabolically. So type 1 diabetes is relatively common. It definitely has a different prevalence across the world. Areas like Finland and Sweden have the highest incidence of type 1 diabetes, and countries like China have a very low incidence of type 1 diabetes. And here in the US, we're seeing this disease develop most commonly in non-Hispanic white children, although we're seeing a dramatic increase in minority children recently. We do see kind of 2 peaks, although you can be diagnosed at any age. I've diagnosed infants with type 1 diabetes, and you can be diagnosed in adulthood with type 1 diabetes as well. But we typically see this around 4 to 6, and then again at 10 to 14. But it can happen at any time in the lifespan of the person. And there is a genetic component to this, not as strong as type 2 diabetes. But if you have a family member, especially a first degree relative, your mother, your father, a sibling, your risk of developing type 1 diabetes is increased. I have a pair of twin girls in my practice who were diagnosed within 5 months of each other. So that was a big month for big year for their family. All right, so what is this disease? What am I talking to you about this morning? So type 1 diabetes is what we call an autoimmune disease. And this is, especially in the world of COVID, it's important to differentiate this between an immune deficiency. So this is not an immune deficient state, but it's actually autoimmune. Your defense system is more overactive and is targeting the cells within the pancreas that make insulin. So we completely lose the ability to make insulin. So you're in an insulin deficient state. Okay, these cells that make insulin are called the beta cells, and they reside in clusters or islands or islet cells, depending called sometimes, and those are producing insulin. And then once they're destroyed, about 80% of those are destroyed. That's when we start to see the clinical signs of diabetes, when the blood sugar rises. And those are the classic things you hear: increase in thirst, increase in urination, severe hunger, weight loss, all of those things. So this is a picture of the tiny little islet cells within the pancreas. So this is a complex slide and one I use more for a medical student resident lecture, but I think it's important to point out as far as the timing of diabetes. So what we are seeing is a genetically predisposed individual. Again, why we're kind of seeing this, you have a higher incidence of this happening if you do have a family member with type 1 diabetes. And they're exposed to an environmental trigger, which we don't know what that is yet, and there's a lot of research going into that, which triggers the autoimmune destruction of the beta cells via the autoreactive T cells, and that's just a part of the immune system. So you'll see at the very end, on the very right side, where you see the words overt diabetes, and that's referring to the clinical symptoms. When most of my patients are presenting in my office with increase in thirst, increase in urination, they're losing weight, and they don't know why. But this process is actually starting several months to years prior to that. And so that's where I highlight this, because that's where a lot of research is going in. What can we do before they get into my office? How do we prevent this this disease from ever coming to fruition? What can we do to stop it in its tracks, essentially? There is something important that will distinguish type 1 diabetes from type 2 diabetes, and that's something called autoantibodies. So we can measure these in the blood of patients that come in. And if I am not totally sure of the diagnosis, because we know there's a huge obesity epidemic in our country, especially in this state. And so there are a lot of children who come in that are overweight and may have other risk factors for type 2 diabetes. And I'm not exactly sure. And it's extremely important as far as their prognosis and their treatment plan that we kind of differentiate between type 1 and type 2. So this is something specifically that we can measure in their blood to give us an idea. Do they have that autoimmune process or not? All right, so environmental triggers, that's a huge kind of concern especially from parents that come in. What did I do to cause this in my child? Was it something they ate? Is it a vaccine that I gave them? There's a lot of worry in that, and basically we don't know. We've studied lots of things. Cow's milk, there was a theory that if we were giving too early of an introduction of cow's milk protein, like for infants that are on formula, it was that making them increased risk, and that never panned out. I think, right? Yeah.
Goodness.
Vaccines, there's never been a relationship. There's actually potentially some data that suggests immunizations against mumps and pertussis maybe decrease the risk of type 1 diabetes. So another talking point. And then there's the hygiene hypothesis. Do we live in a world that's too clean? We're not exposing kids to dirt and viruses. We're Cloroxing every surface before they touch it, and we've gone way back that way since COVID. And so their immune system just is hyper-reactive when it does encounter something. And I think the most likely link is a viral agent, although we're not able to delineate exactly which one. But we definitely see an increase in diagnosis rate in the winter months. And there's a lot of study going into COVID and seeing more diagnosis in children. Anecdotally, I think our rates have been about the same. We probably get 1 to 2 new patients in our office per week. In some weeks, it's been more than that, especially in the winter. I wouldn't say it's exponentially more during this last year. So this arrow is highlighting, again, that slide I showed you a few slides back about the moment of diagnosis, kind of when the child develops overt diabetes. So symptoms of diabetes, it's important to be keenly aware of these and talk to your children, your grandchildren, your neighbors, nieces, nephews, if they're starting to say, my goodness, this kid goes to the bathroom every 30 minutes and I can't keep enough water available for them, and we need to be thinking, diabetes. So an increase in urination, an increase in thirst, polyphagia, an increase in hunger. So they're starving all the time because they truly are starving. They're eating, but they're not able to process any of the sugar that they're taking in. Unexplained weight loss. Almost universally, the parents will say, well, I thought they were going through a growth spurt, shooting up and just thinning out, which is very common. But another key question I like to ask is, are they getting up at night to go to the bathroom? Because that's pretty abnormal for kids to have to get up at night to go to the bathroom and drink. And the later signs, the more concerning signs, are if they develop nausea, vomiting, really fast breathing, or they can have a fruity odor to their breath. This is a sign that their body is entering a dangerous metabolic state, a state of acidosis. When they're not able to process sugar for energy, they start breaking down fat, they start breaking down protein, and there's some more dangerous byproducts of that can lead to pretty severe metabolic consequences. And the child could end up in the pediatric intensive care unit. All right, so diagnosis, how do we diagnose type 1 diabetes? Very similar criteria to diagnosing type 2 diabetes. There's not special numbers for children versus adults. The hemoglobin A1C number, that's an average of the blood sugar over 3 months. Okay, it's a little bit of a different scale than what we're used to. It's represented in a percentage. But instead of just checking a blood sugar once and getting a one-time snapshot of what the child's blood sugar is, it's a 3-month average. So if it's greater than 6.5, that is in the diabetes range. If they're fasting blood sugar, so they go 8 to 10 hours without eating or drinking anything, and they wake up and it's greater than 126, that's abnormal. We don't really do oral glucose tolerance tests where you have a baseline blood sugar, give a sugary drink, and then check it 2 hours later. It's there if we need it. And then if they have a random glucose, this is more commonly what I see, greater than 200, plus the symptoms, increase in thirst, increase in urination, then we can make the diagnosis based on that. And then I have a big yellow star here, and this is part of my presentation for residents, is that obese children can have type 1 diabetes, and it shouldn't be missed. And I've had several patients who are treated with metformin, which is more of a type 2 or prediabetes drug, instead of insulin, and they end up very sick because they have the wrong treatment in the beginning. So it is really important that if they see a specialist, that they get on the right course in the beginning. This is just a quick chart to show you kind of the hemoglobin A1C and blood glucose equivalency. All right, the management of diabetes in children. So the problem that we've talked about is that it's an insulin deficient state. The child's pancreas is no longer making insulin, so we're going to give them insulin. And that it's a scary diagnosis when the kids and the parents hear that they're going to get 4, 5, 6 injections per day for maintenance. They have to check their blood sugar several times a day. This at least every 3 months for hemoglobin A1C and titration of their insulin. There's typically 2 ways we can give insulin. One we call multiple daily injections, and that's insulin shots. And then an insulin pump, the fancy name for that, continuous subcutaneous insulin infusion set. So that's what I got. We also are managing acute complications. So hypoglycemia is defined as a blood sugar less than 70. And that's a more urgent situation, especially in children, because they have a lot of trouble recognizing when their blood sugar is low, especially if they're very young and if they're very new in their diagnosis. And then we talk to them a lot about management of hyperglycemia, which is certainly much more common when their blood sugars are too high. You just don't want it to go on too long and to be too high, because that could be their risk for DKA or diabetic ketoacidosis. And then we like to manage, we're doing all of this intensive therapy so we can manage long-term complications of diabetes. And those I know you all are familiar with. So the same things that happen with patients with type 2 diabetes that's not controlled can happen if you don't control your type 1 diabetes. And that's the retinopathy in the eyes, so the blindness, kidney problems, and then the neuropathy in the hands and feet as well as the cardiovascular complications. So we are asking our patients to maintain their blood sugars generally between 70 and 180, which is pretty tough and pretty tight. And we want to try to have their goal hemoglobin A1C of around 7. As they get older and they get more comfortable with diabetes management, we shoot maybe a little bit lower than that. But if you aim for too much lower of a hemoglobin A1C, you risk a lot more low blood sugars. So that's why we kind of keep it a little bit buffered. And why do we do this? Why do we want such tight control of their diabetes? And that's related to a landmark study called the Diabetes Control Complications Trial, the DCCT. We'll hear it referenced. So the hemoglobin A1C level is on the x-axis, and then the risk of all of those complications that I just talked about on the y-axis. And you can see that all of those are really minimized if you keep your hemoglobin A1C 7 or less. Okay, so if we're running hemoglobin A1C of 10 or 11, much, much higher risk of developing those complications. And so that's why we have really been a lot more strict. We call this intensive control. All right, these are just a snapshot of all the insulins that we have available. Every doctor will have a little bit of a different preference for what they like to start their patients on. For kids, generally, we implement something called a basal bolus regimen when they're doing shots. So they're going to get one shot at night. Insulin that's going to be in their body for about 24 hours. And then every time they eat, they're going to have to give themselves what they call a rapid-acting insulin or an ultra-rapid-acting insulin to account for what they just had. So a typical morning, like if they were here having breakfast with us, they'd check their blood sugar, they'd create a plate and count how many carbohydrates are going to be on their plate. So a lot of diet education goes into this. And then there's an equation they use to determine how much insulin they're about to eat for what's on their plate. Okay, they add that to another equation that's called a correction factor, and that's a number that's designed to bring a high blood sugar down to within the range that we talked about. And so they get a shot every time they eat. And that's a really hard concept, a really hard adjustment for these families when the kiddos are first diagnosed. Especially when they have that 4-year-old that likes to snack every 2 hours and grab something from the pantry. Right. This is just a profile as far as how long these insulin last. So the straight kind of gray or brown line is the you'll see labeled as Lantus or Levemir. That's the once a day long-acting insulin. And then the black peak is generally what we use for the mealtime. So it's very quick onset of action peaking within the bloodstream in about 30 minutes and then completely out in about 4 hours. And this is just a schematic of what we're trying to do with the basal bolus regimen. So long-acting insulin is kind of covering them for the 24 hours, and then they get a peak of insulin each time they eat. Does that make sense? All right. So I know that kind of sounds all doom and gloom, and this is just a horrible disease and what a tough thing for a family to be diagnosed. But the exciting part of my field is all the research that's going into this. And what are we doing to cure type 1 diabetes? And certainly, if we're not at a cure yet, but delaying the onset of diabetes. And that's been this drug, tocilizumab. I'm sure you've heard of it. But it's a monoclonal antibody that was studied as an infusion in kids who were high-risk patients. So they had a sibling or a parent with type 1 diabetes, and they were noted to have those antibodies that I discussed earlier. And they were able to delay the onset about 2 years in the patients that got this infusion. And now they're currently enrolling patients if they've been diagnosed within 6 weeks to potentially delay the onset, kind of quell that autoimmune response to see if they can delay the onset of this disease. All right, so definitely not a cure, but I think giving us a huge amount of insight into the steps that we need to take to maybe get there one day. All right, just a quick note on diabetic ketoacidosis. I mentioned this earlier in the presentation, but this is the complication for one of my patients outside of severe hypoglycemia. But this is caused when the patient's not giving their insulin or they're not getting it through their pump in an appropriate manner. And it's a state of insulin deficiency. It's associated with high blood sugars. About 30% of kids present in DKA because their parents just don't recognize the symptoms and they go too far down the road. Readmission is most common in adolescents. As you can imagine, those are the patients that get tired of checking their blood sugar. They get tired of giving insulin. They don't want to look any different than their friends. They want to go to the concession stand and eat whatever they want. And that's just not feasible for them at that time in their life. So about 5% of our patients account for more than 25% of admissions. So we have a handful that we really have to work on. We're in the hospital every few months for this. All right. And there's diagnostic criteria on the right as far as their blood levels. Yeah, I'm going to start that right now. All right. So this is one of the favorite parts of my job is implementing these technologies and to help people manage their diabetes. It's never hands off. We are not in an autopilot mode by any means, but we do have some technology that makes it easier. So our traditional glucose monitoring was with a glucometer where you stick your finger, you put a tiny drop of blood on a test strip and it tells you what your blood sugar is. So our patients were doing that 4 or 5 times a day. And now we have a technology called a continuous glucose monitor. It's been probably about 15 years since we had the first ones. And each year the technology gets more reliable and just much more user-friendly. So this is a device that stays on the patient, on their skin for about 10 to 14 days, depending on the device. And it's measuring the interstitial fluid, the fluid just beneath the skin, the glucose concentration. And it's constantly sending a reading to the patient or the parents what that child's blood sugar is about every 5 minutes. So it's an intense amount of information. But the beauty of this is some of them have alarms. They can alarm the parent at night if their child's blood sugar is dropping low or if it's going high. It's just a really remarkable technology that in some ways, or in a lot of ways, has made this a lot easier. It is a lot of data. I do think people get data fatigue. They get a little bit overwhelmed with how much information they're getting. But it's life-changing, and it does save a lot of finger sticks. So this is an example. Dexcom is one of the brands that I use a lot. It has an FDA approval down to age 2. So you'll see on that child's left arm, she's wearing the device. You can wear it on your stomach at the top of the buttocks, and it will transmit to your iPhone. It will transmit to your Apple Watch. And it can share with your parents. So that's why a lot of my parents love it, because they can monitor their child's blood sugar while the kid is in school. Medtronic makes one called the Guardian. It has a nice feature that it connects just through the phone with Bluetooth. You don't have to have a separate receiver. And another technology that you've probably seen commercials on is what we call intermittently viewed continuous glucose monitors. So these are like a small patch that's worn on the arm, and then whenever the patient wants to know what their blood sugar is, they scan over, and it gives them their blood sugar reading. And the Libre 2, the next generation that's been released, does have an FDA approval of over 4, and it will alarm for regular blood sugars, which is a new feature, which is nice. and it's much more affordable. So insulin pumps, these are what our insulin pumps used to look like in the 60s and 70s. So we don't see a lot of those walking around these days, so we've come pretty far. So how does the insulin pump work, and how is that different from the injections? So there's no long-acting insulin. There's not that one shot at night that's kind of giving you a protection throughout the day. You have just the rapid-acting insulin in your pump, and you're getting a continuous infusion of that, either through some tubing, which you'll probably see on these pumps that are going around, or the Omnipod, the insulin is encapsulated within the device that's on your arm. And then when you eat, you actually plug in the amount of carbohydrates into your insulin pump, and it does the math all by itself within the pump to give you a certain amount of insulin. And the beauty of this is you can have very precise dosing. For example, for an insulin pen, you can do half units, 1.5. An insulin pump could give you 1.24 units. I mean, it's just extremely precise, which is nice when our children are requiring very few units of insulin per day. So these are there's basically 3 models that we're prescribing right now. The Omnipod tends to be a favorite with kids because it's tubeless. It's pretty bulky. You can see this little guy, he's got that patch on his arm, and you'll see it coming around, comes off the skin about a centimeter and a half, and that's full of insulin. And then he carries something called a personal diabetes manager. Right now, at the latest one, it looks like a cell phone, so the kids think they're super cool. And it helps them program how much insulin to give, and there's some quick carbohydrates. If they eat the same mac and cheese and hot dog every day, then they can just put in, Sam's lunch, and it gives them the appropriate amount of insulin. So that's pretty cool. Tandem with Control IQ right now has a very sophisticated algorithm, and probably the closest thing we have to an artificial pancreas. You may have heard those words kind of thrown out. And so what this device is doing is communicating with the continuous glucose monitor to be watching what the blood sugar is. So you'll see on the top right corner it says 149, that's the patient's blood sugar. And so that device is transmitting through the Bluetooth signal to the insulin pump. So your pump knows what your blood sugar is. And there's some automated algorithms in the background that are giving the patient less or more insulin based off what their blood sugar is without the patient intervening at all. So that's pretty cool. I've seen kids drop their hemoglobin A1C by 1 or 2 percentage points, which doesn't sound like a lot, but it's a huge difference. Oh, sure. Yes. No, I think 1 or 2 more slides, so that's perfect. So it's very cool. And then the Medtronic has a couple of options out there that are doing something very similar. Their algorithm is different, but it's a very similar technology. So it does a lot of stuff on the kid, and these are tiny little bodies, so you can run out of real estate space pretty quickly because they're the transmitter or the glucose monitor, and then they have an infusion site, and then they're keeping the pump on them. So we have creative ways that we can help them with all this technology. And then this is our hope for the future, is that we develop a true artificial pancreas, where we're not only giving them insulin, but potentially glucagon, which is a hormone that brings your blood sugar up if it's too low. So that's where our hope is, that it can be as hands-off as possible for our patients. So I just wanted to really touch quickly on some local support for our patients. Like Dr. Cyrus mentioned, I do attend our diabetes camp as a camp doctor. We haven't had it last summer and then this summer due to COVID and our high-risk patient population, but hopefully in next year we'll have it. But Camp Blue Hawk's an overnight camp for kind of a teenage age range, and then Camp Low Be Gone, that's such a creative name, is for our younger kids. And so it's such a nice social network for these kids to be able to interact with others who have their same disease, have their same struggle. But there's kids in small towns that they're the only one that has type 1 diabetes. And so it's really enlightening for them to know they're not alone. And then I will just briefly touch on the Juvenile Diabetes Research Foundation that I'm a part of, and Bob as well. And where their advocacy or their focus is on research. That's their main goal. We got to cure type 1 diabetes. Building community, advocacy, and of course fundraising, which has been really hard these last couple of years. But I wanted to just leave you with some hope in what JDRF is doing and endocrinologists and diabetes doctors around the world, what we're doing to try to combat this disease. And we've got really exciting things. The artificial pancreas I've mentioned, beta cell replacement, immunotherapies, beta cell regeneration, all of this stuff is really exciting, and I'm excited for the next 30 years or so of my career to see really how this disease changes. And I really hope that maybe by the time I'm ready to retire, I'm out of a job, and like this disease doesn't exist. I'd be fine with an early retirement. And that's all I have. Yes.
It's a limiting factor for every one of your patients not having a continuous monitor cost or availability.
Definitely cost. So we do have, the majority of my, probably 50 to 60% of my patients are on Sugar Care or the Medicaid for Oklahoma. And we have advocated and gone to the legislature, and it has recently been approved, although as you know, there's 3 or 4 hoops to jump through to get it. But that they are paying for that now for our patients if they qualify. But private insurance, it can be thousands of dollars per month out of pocket for the Dexcom, the one that I had mentioned. So no, the supply is definitely there. It's cost prohibitive.
Although they don't realize that insurance companies that treat a kid for DKA for 2 days is probably $10,000 per month.
Exactly.
The science of organ transplants and donations and so on is pretty amazing anymore. Any chance of pancreas transplants ever going to happen?
Yes. So the pancreas transplants have been performed. It's generally combined with a renal transplant, like if the patient has, or another organ. The downside and why we don't do it with every patient is that immunosuppressive drugs almost have more dire consequences, especially in a growing child, like chronic steroids, than insulin, which I know sounds outrageous and everyone might have a little bit of a different opinion on that, but that's why it's not routine. I think the exciting thing in the transplant world are the beta cells. You know, we can just put in the cells that are lost that make insulin. And they've done that successfully. The problem is the body starts to, it's a foreign object, and our bodies don't like that, and so they'll start to fibrose over those cells, and it has to have excellent exposure in the blood, so we're able to sense what the blood sugar is and secrete insulin. So any kind of film or anything that develops over that device or those cells would limit it. So they work for 3 or 4 months, but then they stop.
Thank you.
Yes, there, we talked a lot about the pancreas, and of course, a lot of us have a lot of different tests over different organs in our body. Is there a test that says, okay, the pancreas is operating at 50% or 30% or operating too much, producing a certain type of enzyme instead of insulin to kind of help lead into a diagnosis of the future?
Yeah. Well, that's a great question. So the pancreas we can divide into 2 parts. The endocrine pancreas is what I deal with, and that's where the islet cells are, and that's kind of the hormone secreting. Your exocrine pancreas is where your digestive enzymes come from, and generally they, the disease processes that affect those are very separate. So I would say for diabetes specific, if you can, especially with type 1 diabetes, if you can detect those antibodies early in the child, you know they're at risk for developing type 1 diabetes. And there are clinical trials all across the world that will enroll patients in that. And JDRF just came out with a home test. So anyone, if you just are curious, if your child or grandchild or neighbor may be at risk for type 1 diabetes, you can order this test at home. It's a finger poke on a filter paper, and you send it in and they'll run it for you. But we generally don't routinely screen glucose levels or hemoglobin A1Cs in healthy children. There's more guidelines for that in obese children over age 10, or if they're having some symptoms. But I would say without a risk factor, without a family history or any symptoms in children, we're generally not doing just a general evaluation of the pancreas.
Bill, could you bring up the, oh, he's bringing another job, yeah. No, thank you very much. That's, I had no idea how complex diabetes was, and the treatments that are available with technology is just astonishing. As a thank you to you, we will make a donation to Rotary International and polio now. Anything, so you made your name. We appreciate that. Now you need to draw a ticket and see if somebody's going to win some money from them.
Oh, okay.
Last three. The last three numbers.
551.
Did I win? Oh, I don't know.
Sorry. Oh,
You said
God.
5. I said no.
You should buy 5 tickets, no wonder.
I love my chicken. I get $5.
You
I went a date with him.
No, I think it's like $190.
She'll get plenty of money. If she just doesn't get it, it's $5 back. So it's.
King.
King for the day.
Thank you.
You're very welcome.
Okay, we are adjourned. Thank you all. If you have any questions for Shelly, she'll be up here for a few minutes, I think. Okay. So thank you very much. Have a good day.
He's not wrong.
25 years.
Type 2 diabetes, yes.
I think that's somebody else's flash drive from last week. Because remember, yeah. Yeah.
Can I call you today? See the good card?
Oh, yeah. I'm heading up to the lake. I'm heading up to the lake with the
Yeah, great. Thank you.
I don't know how we're supposed to show.
I think you just shut it off.
Yeah.